Any health-related information on the following show provides general information only. Content presented on any show, by any host, or by any guest should not be substituted for a doctor's advice. Always consult your physician before you begin any new diet, exercise, or training program. And thank you for listening to the Whole Care Network.
Welcome to Hospital Warrior, Advocates and Experts, the place to listen for information, ideas, and advice on healthcare advocacy in today's complex medical world. Whether you are the champion for someone you love or want to be your own best advocate, you need facts, guidance, and support. This is the place for you. Now, here's Bonnie Friedman, author of Hospital Warrior, How to Get the Best Care for Your Loved One, and host of the show.
Hi, I'm Bonnie Friedman, host of Advocates and Experts, and I'm delighted to have you with us today. My book, Hospital Warrior, focuses on the needs of hospital patients. This podcast explores what advocates need and delivers experts who can help provide it. I'm happy to welcome you, and I hope you'll become part of the conversation on social media. Today we're going to talk about what makes a good doctor, or for that matter, a great one. Most of us want physicians who are excellent clinicians and diagnosticians, but we also want doctors who are caring, empathetic, maybe even telepathic. Doctors who somehow know intuitively what we want and need without our having to explain those sensitive background issues that we just don't want to talk about. So the question is, are doctors like this born with the qualities? Are they hardwired that way? Or can those things actually be taught? Today we have the right person to ask that question. Franca Posner is a clinical social worker and a psychotherapist. She specializes in grief and loss, chronic and end-of-life illness, adjustment to disability, and so much more. But she also works with the Professional Development Program at the George Washington University Medical School, and that program focuses on exactly these issues. Franca, welcome to Advocates and Experts. We're delighted to have you.
Thank you so much. I'm delighted to join you.
So the question is, are caring, empathetic doctors born that way? Or are these qualities something that can actually be taught?
The answer is both yes and no. There are certainly some people who seek out the helping professions, specifically we're talking about physicians today, who throughout their life, all the way back to toddlerhood, showed signs of exceptional empathy towards their playmates, towards their parents if a parent was hurt or upset. And these skills only continue to develop. There are other people who are incredibly smart. Anybody who gets into medical school, we know they are quite accomplished in terms of their intellect, but maybe are less aware and less in touch with emotions like empathy and compassion.
So are these doctors who are better advised then to maybe go into research rather than clinical practice?
Sometimes yes, but there's increasing evidence that empathy and compassion can be developed and taught. At first, it is not natural, but it can become natural, particularly as these students and interns and residents see the results of it and see how much more rewarding an interaction is if they incorporate the skills of being present, listening carefully, connecting with a patient or a family member.
So how does the professional development program at GW go about teaching those types of skills?
So the program at GW, and there are a large number of medical schools that are adopting similar programs, have, as part of the Foundations of Medicine, starting right the first week that these medical students come on campus, and they're very nervous and they're very excited, a real turmoil of emotion. We start with small groups that pair a physician with a mental health professional. And so I on the team, I'm a mental health professional, and we have somewhere between 8 and 10 students. So there are multiple small groups that work in this format, and we have a series of meetings that we have. We meet more frequently in the first and second year, and a little less frequently in the third year of their training as they are in their clinical rotations through different specialties.
Can you give us an example of how you go about teaching a particular skill or sensitizing doctors to become more sensitive to a particular trait that you're trying to encourage or develop in them?
Absolutely. The example of delivering bad news.
That's a good one.
Almost without exception, the students enter their training thinking they're going to cure people, and that is why they wanted to become a physician. But sometimes people come for whom their diagnosis, the course of their illness, is going to result in death. It might be a cancer diagnosis. It might be something like a neurological disease that's degenerative, like ALS. And so there will be bad outcomes. This has not occurred to almost all students. So delivering bad news is a skill that needs to be taught, and it's really important for us as the mentors to remember that our students are quite young. They're 22, 23 years old, maybe have never experienced the loss of a family member. The idea of death is a bit abstract for them. And so we work often with standardized patients, which is a wonderful component of the program.
Can I stop you right there and explain, please, what a standardized patient means?
Absolutely. It's a wonderful component of our program. We have actors from the local theater community. So these are not Broadway actors, but they are very much present and enjoyed and appreciated by the Washington, D.C. area theater community, and a few employees of the university. George Washington Medical School is part of George Washington University, a much larger institution. Sometimes we have somebody who's in purchasing who just has the acting bug and volunteers to do this. As a way to give to the medical school program.
So these are people who are portraying patients with perhaps some disease or illness, but they're not really patients themselves. Is that?
Exactly.
Okay.
Exactly.
All right. Well, I got you off course there, but I thought it was...
That's okay. That's okay.
So go back to your point, please.
So what would happen is the standardized patient comes in. The students don't know the story that's about to unfold. It could be something like someone might report experiencing pain in their back or their side. Immediately the student's brain starts to go to the intellectual piece of it. Well, it could be this. It could be a muscle strain. It could be everything that they think of. It could be an internal organ inflamed, too. It could be a tumor. It could be cancer. They have to think of all those things and not let their escalating anxiety show while they ask more and more focused questions to try and get an idea of what's going on. The students don't know if this patient is the one with cancer or not, and then we follow it through multiple interactions, sometimes one student takes a standardized patient through the entire process over a timeline of months to years. Sometimes students switch off and they're all enacting, Dr. Smith. But different people in that group of 8 or 9 students follows the patient through a process of initial visit, complaints, testing, test results, diagnosis, treatment, outcome. And it's a very powerful experience to companion a patient through all of those stages of the natural lifespan of an illness.
So much of medicine is geared toward positive outcomes, and both doctors and patients alike always are reaching for that goal. So doctors work to try to treat and heal every patient they can, sometimes not wanting to see the bad news side themselves. And of course, patients and their families, likewise, nobody wants to get to that point of bad news. But like you said, sometimes bad news has to be delivered. And how do you help doctors learn to do that in a sensitive, caring way?
So part of it is modeling. Part of it is feedback from their peers, and everybody learns at their own pace. For some people, it is incredibly difficult to be present, to make eye contact, to stay on script, on task, that I really do need to share this news. And it's like I liken it when I'm working with the students to the shorebird that you see running quick to the waves to find some delicious things to eat, and then running back. They need practice to be able to actually stand still, let the water wash up the news, to share it with a patient. Initially, they do have a lot of anxiety. I often speak to students about finding their own authentic voice, and that evolves over time and with a lot of practice.
Give us an example of what you're talking about. How might you say in a caring way that you as a doctor have bad news to deliver versus how you might say it without so much sensitivity behind it?
So that's a great question. A way to say it, I'll answer it in reverse.
Sure.
A doctor walks in with the lab results. They're carrying their laptop computer. Already, they're looking at their laptop computer. That's strike one.
Right.
They should be immediately connecting with the patient in the bed and their family members. If they start out by saying, well, it's bad news, even if they start out with a little bit of sympathy saying, I'm sorry, but it's very bad news, they're saying, I'm sorry, it's about them, as opposed to it being about the patient and family. It's important for the doctor to instead walk in, laptop closed, sit down, get to eye level with the patient. Hopefully the family is sitting on the other side of the bed, and so you're also at eye level with them. And to take a moment, say, how are you doing today? Let the patient report or the family member report on how the night was, how things are going on. And then to say something, give a little bit of a lead-in sentence, such as, unfortunately, the news is not what we had hoped for. So it gives them a little bit of time to adjust, to know that bad news is coming, and to be ready then to hear as much of it as they can take in that moment. It's also really...
Go ahead.
Go ahead.
No, go ahead.
It's also really important for the doctor to check back in later that day or the next day and say, I shared some difficult news with you yesterday. I just want to check back and see what your understanding of it is, because that was a lot to take in.
Those are such good and powerful points. And I liked where you started that with the idea of the doctor sitting down eye level with the patient, because so much of a doctor-patient relationship ends up being the power of the position, I'll call it. The patient's laying down, the doctor's standing up, and often, if there are family members, they're standing up too. And they end up talking back and forth over the patient. So the idea of the doctor sitting down, eye level, and comfortable with the patient just seems to me like such an important starting point for that type of conversation, and probably any other conversation that takes place between the doctor and the patient. And then the checking back. I think that often doesn't happen, especially in a hospital setting where the doctors are constantly having to check in with their watches and clocking their time, and going back and doing that important follow-up so often gets lost in the bigger shuffle taking place. I wondered, Franca, if you might from that go to the question of looking at a whole person, I'll say patient, but really whole person, not just the disease or illness that's afflicting them.
Yes, absolutely. And there, as a social worker, that's one of the foundations of our philosophical approach to working with individuals, whether they be someone in treatment for anxiety or depression, or someone with a severe medical illness for which there might be examples of anxiety or depression. Social workers work very, very hard to train physicians to adopt some of these core values, looking at the intellectual, the psychological well-being, the physical well-being, the spiritual well-being, which may or may not be tied to religion. Spirituality is often described as what gives meaning, what holds meaning for you as the patient. So looking at the whole individual. And doctors are trained to look for what is the cause of the distress, the illness, the crisis, and then to eliminate the things that might or might not be, and to get to the end point, not to look at the whole person. That's shifting, and that's what a program like this does, is to help the emerging physicians be mindful of that whole person always being present and themselves being present to that person.
And I guess that leads to something we might call cultural awareness too. When looking at the whole person, where is that person rooted? What are their cultural preferences or ties? Maybe they come from somewhere outside the United States, and they bring with them certain preferences or values that may not be known to the doctor to start. So are there some cues that doctors should be on alert for in assessing a whole person, not just the patient's illness?
Absolutely, and I'm so glad you used the word awareness, because the jargon used to be cultural competency.
Oh, right,
but
yes.
We have come to learn in recent years, as America continues to become more and more diverse, that there's no way we can be competent in all the different cultures that the patients bring to us. And so awareness, and for example, you might if somebody was brought up in an Asian culture, there is a lot of respect for the medical profession, and they may nod to everything you say. They may have little to no idea exactly what you're saying about them and their illness, or, a family member might also be nodding, not really understanding what you're saying. To not assume that that is a sign of understanding, but ask for that repeat back maybe in an initial encounter instead of the next day. That's one example. Another is in some of the Muslim cultures, a man examining a woman is completely culturally unacceptable. So it would be very important to have a female physician, a female nurse, interacting with a female patient. So there are so many different cultures that we have, particularly in a larger city in the United States. And it's really important to either know the information yourself or go to, and there are resources within almost every hospital that can help you understand the nuances of that culture.
And when you're saying you're talking about the medical students or eventually the doctors themselves. Right.
Yes.
And not just cultural awareness, but I guess there can be things in a person's individual background that might affect their prognosis or diagnosis even, or maybe just their interaction. And I'm thinking perhaps they had a substance abuse issue in the past, or maybe they're the survivor of some sort of violence or abuse. All of those things would have some impact on not only the diagnosis itself, but equally important on the interaction, the trust level that a doctor can establish with the patient in order to really create a relationship that lends itself to a positive interaction with the best possible outcomes you can hope for.
Yes, and that is a very good example. What comes to mind is if there's a history of abuse or trauma, the importance of creating what feels like a very safe environment where there are no sudden blood tests, where everything is explained carefully. If the patient has some dementia or confusion connected with the illness, to come in very calmly, very slowly. I'm reminded of a case where there was a very ill man who was actively dying, who had served in Vietnam, and he had a lot of agitation. He had not had it earlier in his care through a hospice, but towards the stage where he was actively dying, he was very agitated. And he was very paranoid about people coming in. And there was a nurse on the team who was a veteran themselves of the Vietnam War. And the nurse said, let's use some military language. The perimeter is secure, sir. Using that kind of language, and this nurse kind of coached the team, the patient de-escalated. He would check in and say, is everything okay? And some of this language, some of this Army jargon was actually quite useful in calming this patient without over-medicating him, but giving him a sense of safety, even though he had had very traumatic experiences.
So, of course, no doctor could possibly be aware of everything that is unspoken in a patient's past. If the patient or the family hasn't reported it, the doctor may have no way of knowing it. But there may be signs perhaps that something is not right for the patient. And I'm wondering if you could give some example. You gave one of a veteran who probably had PTSD, but what are some other things that doctors can be trained to look out for so that there's a cue there that tells them something's not right, I need to pay attention to that signal?
One example is there abuse that the patient has suffered, and they might be very hypersensitive to touch. For example, a phlebotomist comes in to draw some blood for some lab work, and they become very agitated, very withdrawn. You can see the fear in their eyes. When I'm working with a group of students, I tell them to trust their spidey senses, because you do get a sense of dis-ease, your uneasiness, and the root of the word disease. When you see people with very frightened expression on their face, very tight muscles, someone who you haven't experienced enough to know their personal history. Is a family member so close to them and seems to always be answering for them that you feel you're not really getting the patient's story?
Oh.
And something just feels member to come out into the lounge area so that you can ask a few questions. You want to check in. Is there anything that you feel you'd like to tell me would be a question. Is there anything that is frightening or upsetting you? So some open-ended questions.
Or likewise, I might guess that you want to get that family member who's taking over out of the room so you can have a more honest conversation with the patient directly.
Yes, absolutely, absolutely. So that would be an example of unspoken things, but you just have a sense that something's a little bit off and you're not sure what it is. You may or may not uncover it. Sometimes some of these interactions are very brief in nature, particularly if you're in an emergency room or a critical care ICU. It's a real luxury, but it's where the students in their clinical rotations, I think, learn the most to have an interaction over time where they are able to have multiple interactions with a patient in the management of their medical issue, their disease process. Sometimes it's an interaction for good reasons. It's a high-risk pregnancy, but there's a good outcome at the end. Those are very rich learning experiences that the students have.
I guess it comes down to teaching a sense of sharpening your antenna, if it were, getting that antenna up there as high and as sensitively tuned as you possibly can to be aware.
Yes, that's a great analogy. And, you know, when I say spidey senses, I guess I'm playing to the audience that these students have grown up on Spider-Man. But yes, and to not assume that the way your antenna is tuned when you're doing a rotation in the neonatal intensive care unit where you have to deal with the infant, the doctors and nurses, and the parents, it's going to be tuned to a slightly different channel when you're working with elderly patients who have an illness, such as a blood clot, but also have dementia. So they're not going to be reliable historians, but yet you can have quite rewarding interactions with somebody who's not able to speak. The baby isn't able to tell you what's wrong. The person with dementia isn't able to tell you what's wrong, and yet you can be very present to both.
Well, this is really, I think, uplifting for all of us who see a doctor or have a family member who goes to the doctor or has to go to the hospital. And of course, that's just about all of us. The idea that doctors can be trained with these sensitivities and care that we so much want to be part of the medical practice, not just someone who knows the diagnostics and someone who's studied hard, but someone who's really personal and looks at us as a whole person. It's the kind of medicine we all want, and it's encouraging that programs like the GW program are there to help develop it. Franca, if people want to know more about the GW Professional Development Program, where do they go?
Well, first of all, they can certainly be in contact with me, and I think you are able to share my contact information. Am I correct about that?
No, I think if you want to share it, you can do that, or if someone contacts me through my website, I'd be happy to pass it on. My website is hospitalwarrior.com. You can contact me, send me a message, and I'll tell you how to get in touch with Franca. But I'm wondering if the George Washington Medical School has a description on their website of the program as well.
They do, under professional development, but be sure and look at the medical school website, not for the entire university.
Right. Okay. So that's George Washington University Medical School, and look for their professional development program. Before I let you go, I know you also had a few resources you wanted to mention, books that you think are great sources of more information on this subject.
Yes, I would first of all recommend Rachel Naomi Remens, that's Remen, her book Kitchen Table Wisdom, and she is herself a physician, and she is also a patient who has had a serious illness throughout her adult lifetime. She writes exquisitely about the lost art of being present to each other, the way we used to sit around the kitchen table 50, 100, 200 years ago, going back to when tables were first invented. And how so much is lost by us not listening to and hearing each other's stories. We're in this technology age where you could even be sitting at a table and everybody's texting the people on the other side of the table.
All right. What's the next book you had to mention?
Yes, I would like to mention a new book called In Shock that is by another physician, Dr. Rana, R-A-N-A, Awdish, A-W-D-I-S-H. She is a critical care physician who became unexpectedly a critical care patient, and she talks a lot about the medical culture and the way doctors say things that end up being damaging to patients, and she has started a program at her hospital in Detroit to address some of these very same issues, and it's a very gripping story and beautifully written.
Well, that's great, and we appreciate all of that additional resource that you've provided. And thank you for sharing so much of your time and your information with us. It's been a real learning experience for me, and I would imagine for our listeners as well. So thank you, Franca Posner. This is Bonnie Friedman, and I thank all of you for joining today's conversation about advocates and experts. Until next time, stay healthy, be safe, and please take good care of yourself.
You have been listening to Hospital Warrior, Advocates and Experts, hosted by Bonnie Friedman. You can follow Bonnie on Facebook or Twitter, or contact her with an idea for an upcoming show by going to her website, www.hospitalwarrior.com. Hospital Warrior is all one word. You can also access her podcast there and on the Whole Care Network.